Hello all. So I'm Cristina Sadowsky, and I will make the transition in between the acute care and integrate it with the initial part of rehabilitation. I'm just going to set up the stage for rehabilitation because my two colleagues, Amy and Megan, will come back with details. I have no financial interest, and as you heard both Dr. Briggs and Dr. Carpenter, there are some things that are needed while the child with acute flaccid myelitis is in the acute rehabilitative stage. So pediatric rehabilitation medicine consultation, it's something that should be considered early initiation of mobilization, including physical and occupational therapy and speech therapy should be started, and recommendations regarding positioning, splinting, bracing, communication, and swallowing are recommended. Augmentative communication is important. Because, as you heard, children with acute flaccid myelitis are very weak, and it might be hard for them to express pain and needs. And then psychological support, I cannot tell you how important it is to start it very, very early. All of the notions that were brought in, the autonomic nervous system dysfunction that was brought in earlier by Dr. Carpenter and Dr. Riggs are influencing and affected rehabilitative care. So I do have a little bit of data about some children that we've seen that exhibited this specific happenings and how they were handled in order to optimize rehabilitative interventions. So I have two children that I will take you through my whole presentation with the same pair. It's a little 4-year-old girl and a 3-year-old, and that's the age at the time of onset, boy. They were cases that occurred in 2018, and they had a very, very similar start. And while their neurologic and functional deficits are not the same, you will see that pathophysiology-wise, they are very much similar. So both of them started having problems with upper respiratory tract infection towards the end of September, beginning of October. Was treated, the symptoms were treated just pneumonia or upper respiratory tract infection. They were sent home, and then they started having progressive weakness. The little girl started having lower limbs weakness. The little boy started having a right upper extremity weakness. They presented to the emergency room with the onset of weakness, and then they were quite quickly diagnosed with AFM. In the case of the little girl, AJ, she was diagnosed with AFM day 2. JH, the little boy, did take about a week for a final diagnosis. Diagnosis was based on clinical presentation, on the typical MRI findings, and I want to show you, this is AJ, the little girl, this is the little boy. They are very similar in their MRI presentation. Both of them required admission to the ICU, and then they needed to be intubated quite early after admission. The autonomic system involvement was presented as cardiac rhythm dysregulation, blood pressure dysregulation, and temperature dysregulation, in addition to the bowel and bladder retention that I am not going to talk about. Why am I talking about this is because autonomic nervous stability is really important when we're talking about mobilization, and because the pharmacologic intervention that we apply to manage autonomic instability does affect how we perform rehabilitation and the rehabilitation outcomes. So this is little AJ. In the first 30 days after the admission, these are basically her recordings of her heart rate. And if you see for a whole month, it's actually for the first 2 months, and she didn't spend all of that in the ICU, her heart rate was all the way up into the 140s and an average, with spikes to 200. The heart rate only dropped into the 100, 120s about 2 months or more after onset of neurologic deficit. And it did require pharmacologic intervention. In this case, she responded well to clonidine patch. I do believe she did have propranolol tried, which is a beta blocker, and that did not work too well. The second part of the cardiovascular dysregulation is hypertension, which we've noted that it takes a little while for onset, about at the end of the first week, beginning of the next week or so. And it is persistent for a very, very long period of time. And when I say long period of time, it's actually persistent over months. And again, it does require a pharmacologic intervention for management. In this case, as you see, propranolol and clonidine were both tried. Clonidine patch doing better than propranolol. Kind of a similar situation for both HA and JH. Temperature regulation is also it's a job of the autonomic nervous system. So what we've noted is that the temperature is elevated in the first week or so in all of the children with AFM, or most of the children, in most of the children with AFM, despite multiple antibiotics and workups. Yes, there is the possibility of children having superimposed pneumonia, but in this 2 cases that I'm presenting, that was not the case. So as a summary of the cardiovascular dysfunction, we have autonomic dysregulation as being present. It is manifested mostly as tachycardia, or the bradycardia and junctional rhythm can occur. The tachycardia occurs early and lasts for a while. Hypertension is has a little bit of a delayed onset and persists for a prolonged period of time, and does require pharmacologic intervention. Temperature dysregulation, it's early, is self-limited after weakness. And one interesting thing is orthostasis was not really observed in this children, at least in our experience. I am moving to the respiratory failure part, because again, in order to exercise, you have to be able to breathe, and breathe well enough to sustain the exercise. And I am pretty sure that all of the parents of children with AFM that are right now on this call know that at some point a judicious timing of therapy needed to be made, and time for ventilator weaning was given priority, and then time for therapy was given priority at a different time. So Dr. Carpenter presented, and Dr. Briggs presented the data about the ventilator support need in children with AFM. The respiratory concerns in AFM from a rehabilitation point of view, there is this increased chest wall compliance, because the muscles are weak and floppy. The trunk is floppy, the limbs are floppy. So there is this chest compliance that is increased with ineffective coughing, leading to subsequent accumulation of secretions. In addition, because of the autonomic dysfunction, there is sometimes increased production of secretion, which obviously makes a bad situation worse. And it was mentioned, although it wasn't named, ventilator-induced diaphragmatic dysfunction. This is what happened to the ventilator, what happened to the diaphragm when it is a muscle at rest because of ventilator support. Every muscle at rest atrophies. So full ventilator support, if not needed to sustain life, needs to be backed off in order to be able to give the diaphragm a chance to strengthen and maintain trophicity. And diaphragmatic pacers, which Dr. Briggs did mention, that some centers offer that option. Obviously, we're one of the centers because we're both at Hopkins, so that's how we know each other. Anyway, there is data regarding diaphragmatic pacing and phrenic nerve pacing since the phrenic nerve pacing since the 70s, diaphragmatic pacing since the first decade of 2000. These are two different concepts. They both use electrical stimulation to stimulate a muscle, in this case, the diaphragm. The phrenic nerve pacing actually uses the phrenic nerve as a conduit, so the electricity is transmitted through the phrenic nerve, and the phrenic nerve is stimulating the diaphragm. The diaphragmatic pacer is direct insertion of electrodes into the diaphragm, which can be done through laparoscopic intervention. The two children that I talked to you about, I'm bringing them from the cardiovascular dysfunction. I'm bringing them to the respiratory dysfunction because both of them have been managed with diaphragmatic pacing. Diaphragmatic pacing has been initiated in AJ at day 20, so this is very early after the onset of a neurologic injury. I have to note, and I'm pretty sure that Dr. Matt Ehrlich would talk about the fact that nerve conduction study, surface nerve conduction study of the phrenic nerve showed no activity. Despite that, laparoscopic intervention, an insertion of stimulators into the muscles, into the diaphragm, was able to elicit movement, and better on the left or only on the left, not on the right. That could have been maybe prognosticated by the fact that there was excursion that was identified with the ultrasound prior to insertion of the pacer. The little boy, JH, had his diaphragmatic pacers inserted about 5 months after. It was yearly similar, so left diaphragm contracted better than the right diaphragm. And these are some EMG pictures. This is recording the EMG activity directly from the muscle, which is another good thing and the benefit of why we could use the pacer. Not only that, we can pace the muscle, but we can also extract the information. We can take a look at how is the muscle moving. And if you see here in this, you see all of this are actually spontaneous generation of diaphragmatic muscle movement on the left, nothing on the right. We had the chance of doing more extensive electrophysiologic monitoring because of having the spacers in. We were able to record the activity over a night or during a period that children would be in therapy to see how they trigger diaphragmatic movement while in therapy. This is what a normal diaphragm looks like. This over here, is the diaphragm of little AJ, the little girl, while she was supported by the respirator, by the ventilator. When we took away the support from the ventilator, this tracing shows that she is starting voluntary contractions that are recorded by the EMG. So this is my proof to you that ventilator-induced diaphragmatic dysfunction happens. A muscle arrest is not a trophic muscle. The fact that the electric stimulation did improve the breathing and the respiratory muscle function is in this table, in which we're looking at tidal volumes that well, first of all, she was able to tolerate increasing amount of time during the day. Towards day 19 after the insert, she was able to tolerate 12 hours of pacing, and her tidal values on the ventilator were between 100 and 180. With the stimulator, added stimulator, they would increase by 50%. This is the little boy. It's a bit of a similar situation. He has a little bit more function on the right than the left. Similar numbers, despite the fact that his pacer was inserted about 5 weeks later. We developed a weaning protocol that takes in consideration the ventilator support and the usage of the diaphragmatic pacer. And I rush to the end because I want to keep everybody on time, but I cannot stop thanking the group that is working together to make these children, to get the best rehabilitative intervention. Nurses, physicians, social workers, therapists. A specific thank you to Janet Dean. Hello, Janet. Thank you so much for everything you do. And of course, my colleagues, Dr. Pardo, Elric Melacosta, Kofi, and Dr. Jelen, Dr. Edmiston, and the PQ team. But most of all, thank you to our children and their parents. And now it's my privilege to introduce Amy Bayless and Megan Moore. They are exceptional, fantastic therapists that are passionate about what they do, about children, about science, about clinical care. They are both in the pediatric ICU at Johns Hopkins, and they will take you through a whirlwind of what to do when the child with AFM is in the ICU.